Good evening, all. Today I'll be presenting a USG case presentation class. So this is a case one, 63-year-old female presented with diminution of vision and redness in right eye since 6 to 8 months. Her right eye best corrected visual acuity was 6 by 18 and left eye was 6 by 7.5. Intraocular pressure in both the eyes were 14 mercury. And she had no history of trauma, surgery, any medication or systemic illness. So this is a ultrasound scan. The first scan is an axial scan showing lens echo. Vitreous shows low reflective dot echoes, and in the other scan we can see that there is a medium reflective membranous echo with a fine membrane bisecting that. This first dome-shaped echo, it is suggestive of coronal detachment, and the fine membranous echo bisecting that suggestive of vortex vein. And these are the scans from the other quadrants. So this patient had serous coronal detachment. The highest height was noted to be 9.36 in nasal quadrant. And this is a optos of the same case, suggestive of highest height of serous coronal detachment in the nasal quadrant and shallow CDs in the peripheral quadrant here. So this was a case with serous coronal detachment and diagnosed with low flow keratoconus fistula, and this patient was referred to neurosurgeon for further management. Now coming up to case 2, it's a 61-year-old male presented with diminution of vision 1 month after cataract surgery. He had cataract plus trabeculectomy 5 months ago. His best corrected visual acuity was 1 by 16 right eye and left eye 3 by 60. Intraocular pressure in right eye was 8 of mercury and left eye was 13 millimeter of mercury. And this is a USG scan. The first one is the axial scan showing iode reverberation. Vitreous shows low to medium reflective dot echoes, and we can see there are two hyperreflective membranous dome-shaped echoes. The other scan is in other scan we can see that it is suggestive of a serous coronal detachment with the highest height of 7.8 in the nasal quadrant. And on doing the further scan, other areas, we can see that there is a highly reflective membranous echo with less after movements suggestive of retinal detachment. So this was a case with uh, 360-degree serous coronal detachment with inferior exudative retinal detachment. The third case, 65-year-old male, presented with diminution of vision in right eye since 15 days. He had history of right eye cataract surgery 3 months ago. His right eye best corrected visual acuity was 3 by 60 and left eye was 6.6. Intraocular pressure in right eye was 8 millimeter of mercury and left eye was 16 millimeter of mercury. And this is an Excel scan showing IOL reverbation. And vitreous shows low to medium multiple dot echoes, and we can see that there is a highly reflective membrane, V-shaped membrane that is attached to the optic nerve head with low after movement suggestive of retinal detachment. And these are the scans from the other areas. Uh, the, the first one is supratemporal and infratemporal scan suggestive of serous coronal detachment with second membrane suggestive of retinal detachment. In the next scan, we can see that highest serous coronal detachment height was in supranasal quadrant, it was 2.49 and we can see there are two spikes. Highest spike is suggestive of retinal detachment, and next to that is a coronal detachment spike here. So this was a case with uh, rhegmatogenous retinal detachment with secondary coronal detachment. Now, coming up to fourth case, it was a 51-year-old male present had history of road traffic accident 10 days ago. His right eye best corrected visual acuity was 6.6 and left eye he has no PL. And when he presented to us, the findings are he had he had full thickness corneal tear plugged with iris tissue and hyphema and with total cataract. On ultrasound, we could see that he had uh, this is a first scan that shows only lens echo is noted, but we cannot comment on the vitreous echoes or retinal echoes. But we can see that there are two dome-shaped membranes, and with this multiple homogeneous echo inside that, suggestive of hemorrhagic choroidal detachment. These are the scans from the all the quadrants. This patient had 360-degree hemorrhagic choroidal CDs, choroidal detachment, and highest height was noted to be in superior quadrant, that was 12.80 m. And on further subsequent imaging, we can see that this is a day 3 ultrasound image, and this choroidal hemorrhagic CD's height started regressing. And on day 6, we can see that there is a equilucent space in the hemorrhagic CD, suggestive of early clot lysis. This is a day 10 image. So with the help of ultrasound, we can also see the clot lysis assess. So USG in choroidal detachment, we can see smooth, thick, dome-shaped membrane in the periphery with little or no after movement. Usually it does not extend beyond the equator as it is limited by vortex vein exit. Massive hemorrhagic CDs can extend up to the posterior pole, and even massive serous CDs do not insert on the optic nerve head. On A scan, the classical sign is M-shaped spike or double peak sign that we can see here. The first spike is suggestive of retina, and the other next spike is from the choroid. It is called M-shaped spike. It is seen in serous choroidal detachment. And shallow peripheral CDs can also have flat or concave appearance. A cord-like moderate to high reflective echo stretch between the sclera and the choroidal dome at the equator in case of bullous serous CDs that represents a vortex vein. So this membrane is suggestive of vortex vein. It is important to differentiate choroidal detachment from the uh, PVD and RD. So PVD will have variable optic nerve head attachment. RD always optic nerve head attachment will be there, and CD's optic nerve attachment will not be there. And usually PVD disappears on the low gain setting. RD and CD will persist, and spike height is variable with the PVD, and RD and CDs will have steeply rising 100% spike. And CD there is a classical double peak spike we can see on USG A scan. PVD will have moderate to marked after movements, and RD will have none to moderate, and CD also have none to mild after movements. So the first video is of RD. It has optic nerve head attachment and it has less after movements. The second video is of PVD. It has the highest after movements. And the third one is a serous CD, which has least after movements. And on gain setting, we can see that the first picture, the gain is 0, and we can see that retinal detachment echo is persist. And while reducing the gain, this echo will remain the same. And CD sometimes we can confuse with retinoschisis. So retinoschisis is usually present in the inferior quadrant, and the membranous echo in retinoschisis will be thinner compared to choroidal detachment membranous echo. Now, this is a case, 46-year-old female. She's a case of Sturge-Weber syndrome. Right eye had no PL and left eye had 6/6. On anterior segment examination, we can see that she had hyphema with a complicated cataract and conjunctival melanosis. So this is the USG scan.
Yeah, so in this scan, you can see the lens echo from, I'll start from anterior posteriorly. The second, you can see one more membranous echo of moderate reflectivity. And third, you see a dome-shaped elevation hyperreflective echo having some homogeneous internal reflectivity. And at the edge of that, on the second image on the right, you can probably see one retinal detachment probably extending beyond the edge, maybe. And what's more interesting is that this mass lesion is extending beyond, and there is a hyper reflective space. Probably it's invading it is going extending into the orbit.
Eye surface reflectivity and the internal reflectivity. Choroidal thickening, hemangium, choroidal hemangium, Oberstone,
So what can it be?
melanoma.
So what are the typical, it is not seen clearly in this, what are the typical findings you'll see in melanoma?
Colisted appearance,
Other features?
acoustic
What
coloring.
is acoustic calling? Any one of you?
Acoustic hollowness, that the reflectivity will decrease when it goes posterior.
That arrow is showing acoustic calling, what is it?
The choroid under the mass, the thickness of that is reduced in comparison to the adjacent choroid. And if you see the A scan, you'll see that the reflectivities keep decreasing because the mass itself is very homogeneous. I think that's called angle kappa.
Previous this thing. Yeah, this one is a choroidal melanoma with an extrascleral extension was seen. So in that image also you can see it is extending into the orbit.
This is a second case, 42-year-old female presented with diminution of vision in right eye for 2 weeks. So her best corrected visual acuity in right eye was 6.9 and 10, and left eye was 6.6 and N6. This is the USG scan of the patient.
Okay. So now someone describe this USG.
Ultrasound B scan with associated with A scan. A scan also that the lens shadow is seen, and after that vitreous shows low to low to low reflective dot echoes, and then there is a hyper reflective membrane like structure with a high A scan spike, and underneath there is one hyperechoic hyperechoic shadow with high surface reflectivity and homogeneous internal reflectivity, suggestive of retinal detachment with one mass lesion.
Any differentials, what can it be?
And the dimension of the mass lesion is also there. The height is 6.09 millimeter, and the transverse in transverse scan the horizontal it is like 10.5 millimeter. There is no acoustic haloing, so suggestive of retinal detachment with
Okay, any other thing? Anyone thinks of any other diagnosis? Anything else you see in the ultrasound which you think it can be for it to be choroidal abscess?
Back shadowing is not there.
Back shadowing won't be there, no.
Where do you get back shadowing?
Ma'am, if calcification is there, then we can get the back shadowing. In hemorrhagic mass, we can get the back shadowing.
Hemorrhagic mass.
Like if blood, like highly vascular structures.
Can someone tell me what highly vascular structures look like on ultrasound? Do they cause back shadowing? If yes, why? If no, why? Why not? Anyone? We can't see any of you. It's better sitting at home. We can see your faces. Yes, Ritika. Vascular structures, will they cause back shadowing? If yes, why? If no, why not? I'm not talking about clot. I'm talking about vascular structures.
Ma'am, vascular structures do not cause back shadowing.
Why? What you see here, is it vascular? Why vascular?
Can be vascular, ma'am. Multiple homogeneous dot echoes
What
are
happens
seen.
when ultrasound strikes
Actually,
a vascular
we can
tissue?
see the mobility. The dot echoes can be moving.
But that depends on the speed of the blood within it. When you have a vascular, what is the basis of generation of an ultrasound image? When do you get an echo?
Sound wave strikes the
Strikes
tissue.
what? Yeah, you need to have interphases, and a vascular lesion is full of interphases. Okay, so when you have a vascular lesion, because you have interphases, you get echoes. You don't get back shadowing because every time the echo comes back, you get back shadowing when? When do you get back shadowing?
When the echo is reflected back.
Hmm?
When all the sound wave is
What does the
reflected
word
back.
back shadow mean? Shadow behind something. When do you get a shadow behind something? Okay, when do you get a shadow? When you're standing outside, when the sun is behind you, when you block the shadow. Which is the structure that is highly reflective that blocks the ultrasound waves from going further and causes backshadowing?
Bodies.
One foreign body, then two calcium.
Calcification.
Okay. So vascular tissues do not cause backshadowing. The tissue has to be highly reflective that does not allow sound waves to pass through it. And that's why you get a backshadow. If you're talking about reverberations, they are different. Okay? The backshadowing is different. Proceed. That's it?
So this patient diagnosis was a choroidal granuloma. And then lately, this is a fundus photograph. Doctors. This patient also had history of, then we asked that patient had history of abdominal TB 20 years ago. She was already treated once with ATT, and she is a healthcare professional. And then on further examination, Monto was also strongly positive. HRCT was also showing changes.
Go back to your ultrasound. Yeah. Now can anyone answer the question what Charanya was asking? What feature is there that suggests it could be a granuloma? Who has the mic?
Subtenon space widening.
Yeah. Okay, you can see that it's there. Granuloma will not cause backshadowing. It will cause the subtenons widening. So you see that under the lesion. Okay? Okay, next, yeah. Anything else on that fundus photo? Anything that you see on that fundus photo? There's something on the mass. What is that? Describe the mass. Out of topic, but it's yellow. It has an RD. It has something else. What vessels? What do you think is there? You see those vessels looping, they go down. A lot of these granulomas have retinochoroidal anastomosis, right? Probably that's, I don't know, I haven't seen the patient, I'm guessing.
Another case, 18-year-old female presented with diminution of vision in right eye since 15 days. She was giving vague history that she had injury in right eye 2 months back. When she presented to us, right eye visual acuity was hand movements and left eye 6.6. IOP was 21 mm of mercury in right eye and 14 mm of mercury in left eye. And she was on topical glaucoma medication. Anti-glaucoma medication is a nil systemic history, and on street-limb examination, we could see that she had NBI, RAPD, and anterior chamber reaction. So this is a ultrasound scan.
What do you see? Describe the ultrasound.
Vitreous membranes show focal traction also. And clump echoes.
Is it a clump echo or was it?
Membranous.
Okay. And Arka, you want to? Yeah.
The ultrasound B scan with A scan graph showing low reflective dot echoes in the vitreous cavity and one hyper-reflective membraneless echoes with high scan spike suggestive of localized retinal detachment with subretinal high reflective dot echoes suggestive of subretinal hemorrhage, and choroidal thickness looks within normal limit. Scleral integrity is maintained.
Is the scleral integrity on the top picture?
One area that scleral integrity not maintained, suggestive of retinal or vitreous incarceration.
Is it incarceration?
USG is important in choroidal detachment for serial monitoring to check for the resolution, choroidolysis, and treatment response, and its association with retinal detachment or T sign. But correlation with history and clinical examination is utmost important. Thank you. And these are my acknowledgements. Thank you.
Thank you. Any inputs from?
So for you to characterize any lesion on ultrasound, make sure that the ultrasound, the beam is passing exactly perpendicular to the lesion. Only then you will get the best, features of that ultrasound. So So some of these images are not exactly the ideal images where you would describe the lesion. So you make sure that you have the ideal scan first. Whenever you are, giving the images, or when you are storing, make sure that you store the ideal images. So try to make sure that your scan is exactly perpendicular to the lesion, and then look at the surface reflectivity, internal reflectivity, and other features. So even that M spike and all what you were showing is not
It's not
exactly
that
ideal
classic, yes.
scan, but I understand probably there may not have been any other scan, but
This
ideally you should have a good scan which is going perpendicular to the lesion. Then only you will see the M spike correctly.
I think first of all, thank you, Mauli. At the last minute, she agreed to present. I think she deserves a good round of applause. Thank you, Mauli.
Thank you, ma'am.